In this lecture, we're going to talk about cancer chemotherapy. Anti-cancer drugs are, of course, one of the key ways we deal with this very serious condition of cancer, along with surgery and radiation therapies. But cancer chemotherapy has evolved into a very important aspect of our treatment of cancer. What we're going to see here are a group of drugs that all share a common goal. And that goal is to have selective toxicity of the cancerous or neoplastic cells. This is a little difficult because remember, cancerous cells are still human cells. When we talked about treatment of infection, we talked about selective toxicity where antibacterial drugs and other anti-infectious agents try to be selectively toxic to the invading microorganism. But of course, the microorganism is not a human cell. So here, the goal of selective toxicity is that much harder. What we'll see is a lot of the drugs try to either disrupt DNA and RNA function in some way, because cancer cells need to use their genetic material very rapidly to continuously replicate and divide. Or some drugs directly inhibit mitosis. Again, with the idea being that cancer cells have a much greater need to do this, to divide and replicate, than a healthy human cell. So what we're going to do is focus on these two aspects as we go through several different types of anti-cancer drugs. What we'll do then is focus on groups of cancer drugs that are classified according to their chemistry or mechanism of action, starting with the alkylating agents, the antimetabolites. We'll get into the antibiotics, the platinum drugs, drugs that affect the microtubules in the cell, topoisomerase inhibitors, hormones, and probably the newest and most important drugs right now, the targeted and biological treatments, and finally a group of miscellaneous drugs. Clearly, this is an extensive list, and we'll see again that we try to find some way in which these drugs are affecting the cancer cell more than the human cell. And some of these drugs do this fairly well, especially the newer agents, the targeted agents. Others, they're not as selective. But let's get started with the alkylating agents, and we'll work our way through this list. So our first major strategy involves the alkylating agents, some of the oldest and most powerful anti-cancer drugs. These drugs bind strongly to certain DNA bases, specifically guanine nucleotides, and they form a cross-link between the DNA strands and within the DNA strands. When they do this, they basically handcuff or tie up the DNA molecule, or more likely, actually cause the DNA chain to break at the point where this drug is inserted. DNA does not like to have foreign molecules inserted into its molecular structure. And when you do this, it often self-destructs and falls apart. So again, these are very powerful drugs like chlorambucil, cyclophosphamide, and as I said, they've been around for a very long time. The problem is they're not very selective. We'll see in the next slide exactly the chemistry of these drugs, and you'll see that wherever they can find the appropriate place to insert themselves into DNA, they're going to do that. So let's see that in the next slide. So here's a schematic of the chemistry of the alkylating agents. They're given this name because they basically form an alkyl bond between two guanine nucleotides. So the drug, the alkylating agent, you can see it in the upper right-hand corner, has attached to one of these guanine bases, and it forms this, again, cross-link or handcuffing effect to an adjacent guanine nucleotide, and this will occur any place in the DNA molecule where it can find this association between these two bases. But once again, it will do this to healthy cells as well as cancerous cells. The reason it's effective in cancer is because the cancerous cells have a much greater need to replicate their DNA. So they're going to suffer more. But unfortunately, the healthy cells will suffer to some extent. And we'll see that with several of these traditional anti-cancer drugs. Let's take a look at our next group now. So our second major strategy are the antimetabolites. These drugs act on the pathways of DNA synthesis. Cells, of course, have to synthesize DNA, and they impair the synthesis by either inhibiting the enzymes that form the DNA, or they act as what I call a bogus ingredient. For instance, the drug substitutes itself for the normal DNA ingredient. I make the analogy that it's like baking a cake, and the recipe calls for a cup of sugar. You can substitute a cup of salt, and they look fairly similar, but the cake is not going to be effective. It's not going to work correctly. So that's how these drugs work. And again, some fairly well-known, well-established drugs like fluorouracil and methotrexate. We'll see this illustrated in the next slide, how these drugs get inserted into the DNA pathways. So when it's time to make DNA, we start by combining a purine building block or nucleotide with a pyrimidine nucleotide to form the ribonucleotides, which are then transformed into the deoxynucleotides, which are then formed into DNA or synthesized into DNA. Some of these drugs, like methotrexate or captoprene, thioguanine, they inhibit one of the earlier steps in this process. Other drugs, cytarabine, again fluorouracil, and so forth, they get involved in one of the last steps. So they don't all work the same way. They get involved in different places in this DNA process. But still, if you interrupt the biosynthetic pathway in some way, the cell cannot replicate its DNA. And if it can't do that, it can't divide, or it can't divide as quickly and as rapidly. So that's how our anti-metabolites work. And once again, they're not very selective. They will affect healthy and cancerous cells at the same time, with hopefully the cancerous cells suffering more. Now, the anti-cancer antibiotics, they follow a similar strategy to the alkylating agents. They are antibacterials. We reserve them for cancer because they're much too toxic to use to treat bacterial infections, and we have less toxic drugs to treat those types of infections. So we reserve these drugs for the treatment of cancer. They also become inserted into the DNA strand. They don't use the alkyl reaction that we saw in our first group, but they insert themselves very specifically into very particular places in the DNA molecule to again inhibit transcription, or even more likely just cause the DNA to break at that point. And you can see the names, bleomycin, daunorubicin, they sound like antibiotics. They have a mycin or rubicin or streptozicin. So if you see these names in a cancer regimen, you're probably talking about one of these drugs. In this illustration, you see the way the antibiotic gets inserted within the DNA molecule, where the DNA strands are the lightish gray structure, the double helix, but there's this other structure in there. The orangish structure is the drug itself. So again, it gets inserted directly into this molecule, binds it up tightly, or probably causes it to self-destruct. Our fourth group are the platinum coordination complexes. They're so named because they contain platinum molecule within their chemical structure. Another way to form strong crosslinks within the DNA to inhibit replication. So we've seen this strategy a couple of times already with the alkylating agents, with the antibiotics. So it's another way to achieve the same goal. And you can see they have platinum somewhere in their name, cisplatin, carboplatin, and so forth. This shows you the chemical structure. You can see the platinum moiety within the molecule. So once again, they're binding into the DNA, tying it up, or probably just causing it to break. This group are the antimicrotubule agents. Now the microtubules, you remember from biology class, these are important in the mitotic spindle or the mitotic apparatus that directs the cell during division to form two new cells. And this mitotic apparatus must function at the proper time and proper speed, proper rate, to allow cell division to occur. You can see it on this diagram here. So some drugs that we're talking about in this group affect the microtubule, impair the cell division. And they do this in several different ways. Sometimes by either inhibiting the microtubular formation, by affecting the rate of formation of this process. We'll see that a little bit more detail in the next slide. This slide shows normal mitosis. Starting in the upper left-hand corner, you can see this mitotic apparatus forming towards the lower pole or lower end of the cell. And If you go to the right, then part B of the slide, it's directing the cell to form two new cells. And as you progress, this apparatus is basically drawing, in effect, this original cell into two new cells. So if we interrupt this process in some way, the cell will either stop dividing or, even more likely, self-destruct, because the DNA in the process of division gets dispersed throughout the cell. DNA is actually a fairly toxic molecule, and we want to keep it locked up or tied up within the nucleus. And if it does get dispersed throughout the cell will often die. So let's look at some of these drugs in the next slide. So we talk about our antimicrotubule agents first by dividing them into the vinca alkaloids, which are described by their chemistry. They were often called the plant alkaloids because they were developed originally from plant sources. These drugs directly inhibit the formation of the microtubule. Drugs like vinblastine, vincristine, vinyl-albine, very, very powerful drugs. Then we have the taxanes, which inhibit the breakdown of the microtubule. The apparatus itself actually freezes about halfway through mitosis, and again, the cell sort of self-destructs at that point. So we see drugs like docetaxel, paclitaxel. Again, if you see tax in the middle of the name, you're talking about one of these drugs. Like the vinca drugs, very, very powerful anti-cancer drugs. Our next group are the topoisomerase inhibitors. This topoisomerase is a key enzyme that you need to replicate the DNA molecule during cell division. So clearly, if you inhibit this enzyme, the DNA will not be able to replicate and will probably break as it tries to divide. The DNA molecule, you can see it here, this large green structure is the topoisomerase. Its actual job is to relieve some of the tension in the DNA molecule as it's trying to divide. The DNA molecule is very tightly coiled, and as you start to replicate it, you need to release some of this tension. It's almost like unzipping a zipper, and the zipper gets stuck. This enzyme, the topoisomerase, relieves some of the tension and allows this unzipping to occur. Without that process, the DNA will fall apart at that point. We'll look at these drugs in the next slide. So we have two major groups depending on which type of this enzyme they inhibit. There's the topoisomerase type 1. Drugs that inhibit this one are etoposide, teniposide, and then the topoisomerase type 2, the irinotecan, topotecan. So two ways to do this. Again, fairly powerful drugs because of the way they work. They initiate really the self-destruction of the DNA during cell division. Now, anti-cancer hormones. We know that certain tumors and disseminated cancers are hormone sensitive. For instance, breast cancers may be sensitive to estrogen and actually have estrogen receptors on the tumor cell that are accelerated by the growth of this hormone. And if we inhibit that effect, that can slow it down, the growth of the tumor. A lot of times these anti-cancer hormones could be palliative. For instance, in symptoms of advanced breast cancer, or prostate, or endometrial cancers. By that we mean they're not going to necessarily cure the cancer, but slow its growth, sometimes along with other treatments like radiation and maybe to prepare the cancer for surgeries. Unfortunately, like I said, some of these treatments are not curative, but we do have other hormonal treatments that are much more effective, especially in some of the disseminated cancers like the leukemias and lymphomas. Let's look at some more examples in the next two slides. So here are some examples. The anti-inflammatory steroids are what we call the glucocorticoids, like prednisone, prednisolone. These are nicely used sometimes in lymphocytic leukemias, lymphomas, and other forms of cancer. Androgens are obviously important in inoperable breast cancer. In other words, if breast cancers are accelerated by estrogen, they're going to be attenuated or slowed down by the opposite hormone, the male hormone. We have the anti-androgens for people with advanced prostate cancer. Aromatase inhibitors affect the synthesis of estrogen and are obviously important in estrogen-sensitive breast cancers. Some more examples in the next slide. Estrogens, of course, important in the opposite type of cancer, prostate cancer in men. Although we do now have the anti-estrogens too for women with advanced breast cancers. Progestins you can see for various types of cancer. And also gonadotropin-releasing hormones can be important in inhibiting the release of the pituitary factors that can accelerate these hormones in various cases of prostate and breast cancer. So many uses of the hormones. We'll see, of course, later that oftentimes cancer is not treated with one drug. So these hormones are often involved in a more comprehensive treatment with other medications, other anti-cancer drugs.
Press pause and read this slide before proceeding to the next one for the answer.
Our next group is arguably the most important drugs that we are developing right now, the targeted and biological therapies. I made the point earlier that most of the drugs we've seen so far are not really specific to the cancer cell. They will affect the cancer cells more because the cancer cells have a much greater need to divide and replicate their genetic material. But it would be a lot better if we could have drugs that are in some way targeted for the cancer cell or in some way affect the body's own ability to target the cancerous cell. And that's what we're going to look at here. So targeted therapies are trying to seek out some characteristic of the cancer cell that does not exist on the healthy human cell. And if so, it may act like a magnet and draw the drug right to it. In addition, biological therapies, the body's own immune system is often good at finding cells that are about to become cancerous or that are cancerous. But the immune system, for whatever reason, is just not being as effective as it should be. So can we use drugs to reestablish that fact, to encourage the immune system to go after the cancerous cells? So our primary biological targeted therapies, we currently have three major strategies. We'll start with the monoclonal antibodies, then talk about cytokines, and then finally the tyrosine kinase inhibitors. So let's see these in this order. So the monoclonal antibodies have been a huge breakthrough in trying to achieve this targeted effect. These drugs are typically developed using cell cloning techniques that manufacture an antibody that's specific for a protein, an antigen, on the tumor cell. And that's our targeting effect. This diagram shows that the antibody is going to be drawn to a specific protein or antigen that's on the cancerous cell. If this protein does not exist on the healthy cell, that drug, that antibody, should just pass it by. The question then is, well, how does this antibody affect the growth of the cancer cell? Let's look at some of those ideas. So when this antibody shows up and binds to the antigen, it can block the signaling pathways that are telling the cell to undergo division. And of course that's a huge benefit, because if those signals are blocked, this cell will not continue to divide. They can also initiate a programmed cell death, apoptosis. Exactly how this occurs is not completely understood, but again, very powerful effect. They can sensitize the cancer cell to attack from the body's own T lymphocytes. Again, helping take advantage of our body's own way of dealing with the cancer cell. And finally, they can inhibit angiogenesis. This is the formation of new blood vessels. A growing tumor has a great need for nutrients and oxygen and will form its own blood supply. If you inhibit that, it can actually shrink the tumor. So once again, these are just some of the ways that this antibody can affect the growth of the cancer cell. Now, you get a sense that these drugs have to be developed relative to the antigen on the specific type of cancer. So here's some examples of that. You have this, first of all, if you see this MAB ending on the end of a generic name, you're talking about a monoclonal antibody, a drug that's been developed using these cloning techniques. So drugs like gemtuzumab have been developed to treat acute myeloid leukemias. You can see some other examples. Again, this drug used to treat chronic lymphocytic leukemia. This drug for colorectal cancer, rituximab, has been around for quite a while now, actually, to treat non-Hodgkin lymphoma. Trastuzumab for breast cancers. And once again, you basically are trying to develop the drug specifically for that antigen that's been identified in each of these types of cancer cell. And we're seeing more enter the market on a very regular basis, and this is really good news. Clearly, this takes a lot of work to develop each antibody relative to a specific cancer, but it does underscore the fact that you're getting this target. Our next biological targeted therapy involves the use of cytokines. Cytokines, of course, are small proteins that play an important role in normal immune responses that deal with cancers. In particular, we have drugs like the interferons and other chemicals like the interleukins. The picture is showing you the families of the interferons, the alpha, beta, and gamma families. So by knowing the structure of these proteins, we can develop drugs that act like our body's own endogenous cytokines and therefore affect the growth of these cancers, or more likely signal the immune system to go after that cancer cell. What do the cytokines do? How do they affect the cancer? A lot of times they serve as a messenger. They activate signals that inhibit cell division or actually promote that programmed cell death we talked about a few minutes ago. In addition, they can have a direct effect on cytotoxic immune cells like the T lymphocytes, the natural killer cells, and basically jumpstart the effect of these cells to go after the cancerous tissues. That's what's shown in this diagram. The cytokine, the purple round structure at the top, is affecting a signaling pathway that either directly inhibits cell division or, even better yet, programs the cell death. Our third biological strategy involves an important enzyme called the kinase, or tyrosine kinases. These kinases are enzymes that are involved in cell signaling and regulation of cell division. Now, clearly something has gone wrong in the cancerous cells. They may have defective kinases that leads to uncontrolled and rapid cell division and proliferation. So by inhibiting these enzymes in these defective cells, we can really have a nice effect in limiting the cell division, a much more biological effect, by affecting these specific biochemical differences in the cancer cell, the defective kinases. So these drugs have also been a nice addition to them. So once again, these kinase inhibitors reduce abnormal kinase activity and therefore limit cell proliferation in certain types of cancers that are involving abnormal kinase activation of the cell. Here are some examples. They have this INIB ending on their generic name. So you can see some of the generic names. You may recognize some of the trade names like Gleevec and Iressa. Very powerful drugs, again, and important drugs in these cancers that have these that are caused by the abnormal kinase activity. And finally, there's a group of miscellaneous agents that in some way are also trying to disrupt DNA structure or cancer cell metabolism. These drugs just don't use one of the mechanisms we've seen in the previous categories. Some examples. There is are drugs that act as an asparaginase that deprives the tumor cell of an important growth factor, asparagine, that the cancer cell needs to grow and divide. The histone deacetylase inhibitors. Histones, of course, are proteins that help package the DNA into the chromosome, and in some cancers, it looks like these histones have become abnormally activated and are helping promote the growth of the cell by activating the DNA molecule to replicate. So by inhibiting that effect, we can have a pretty direct inhibition of that cancer cell division. The retinoids, cancer cells become undifferentiated. They become more primitive looking. These drugs try to maintain that cell functioning the way it should function as its normal cell, skin cell, or a liver cell, or a muscle or bone cell. So these drugs are also helpful as part of a more comprehensive plan. So these are just a couple of other examples of how we might capitalize on some difference in the cancer cell or in some way affect the cancer cell's ability to divide. Now, I mentioned we often see several drugs combined to treat specific cancers. Considering that the seriousness of cancer, you don't have the opportunity to try one drug and see if it works, and if not, switch to a different drug. So we often come at the problem with several drugs all at the same time. And you often see these combinations illustrated by an acronym, which is kind of telling us about the drugs in that regimen. FAC, or FAC, is fluorouracil, adriamycin, Cytoxan, which can be helpful in certain breast cancers. Second example, RCHOP. You can see the acronym responds to the first letter in the drugs that are involved in that specific regimen. And there are many of these. Some of them are fairly routinely used. They're always developing new ones. But the point is, if you see some of these acronyms in a patient's chart or in a patient's drug list, they're really referring to the combination of drugs. It also illustrates that our patients are getting several different drugs, 3, 4, 5 drugs, all at the same time, all in high doses. So there's often no question why our patients are feeling pretty sick when they're going through cancer chemotherapy. Which finally brings us to the side effects. We know that these drugs are very powerful. And as I kept stressing, a lot of the traditional drugs do not discriminate well between cancer cells and non-cancerous cells. So we've all seen somebody that has the hair loss due to cancer chemo, severe GI problems, nausea, vomiting, just loss of appetite, anemias, inhibition of red blood cell production leads to fatigue, neurotoxicity. These drugs are fairly toxic to lots of tissues. We can also add cardiotoxicity to that. Many of these drugs are also cardiotoxic. We see skin rashes and many other possible side effects. These are very strong drugs. Several are given simultaneously, and there's no question why our patients often feel really sick when they're going through chemo. Hopefully this is getting better with some of the targeted therapies, but even the targeted drugs still come with a pretty profound list of side effects. So, and if you look at these side effects, they make sense. The hair loss, the GI problems, this is due to the fact that normal cells are also being affected, that the division of these cells, anemias, production of red blood cells is also being affected because a lot of these drugs are inhibiting the cell division that normally sustains red blood cell production, or the GI tract, and so forth. So once again, there's no question why our patients are feeling really sick. So what are our major concerns when we're dealing with patients who are going through cancer chemotherapy? A lot of times our patients are simply too ill to tolerate physical therapy when they're going through chemo. And we can support the patient, reassure the patient, and let them know, look, there's a reason you feel this bad. A patient will often really want to work hard, and they'll say, I'm going to beat this cancer. I am not going to let the cancer win. And they get very depressed when they're going through chemo because they do feel so sick and so weak. So simply reassure the patient. Say, look, there's clear reason why you feel this way. and we will make up for this on better days. We can help reduce the pain in any way. That's a huge benefit. If we can reduce the need for other pain medications that may also contribute to the nausea and the fatigue, that's a big improvement. So any intervention that's not contraindicated, of course, in the treatment of cancer can be very, very helpful. But we can, again, try to maintain improved strength, range of motion, cardiovascular function when it is tolerated and indicated, when the patient is safe to begin resuming exercise and physical rehabilitation. So once again, reassuring your patient, letting them know we're going to do this. We're going to work hard when you do feel better. I think that's a huge, huge benefit to the patient, and an important role we play in helping the patient deal with this pretty profound illness known as cancer. Now, some other issues. We do have good success in certain cancers, and we talk about 5-year cure rates and 10-year cure rates. But in certain cancers, especially lung, colorectal cancer, breast cancer in women, prostate cancer in men, the success rate is not as good. This slide shows lung cancer, and this has got a lot of people concerned because lung cancer, if you look at the darker blue line, is clearly on the rise in women. And if you project it up into the next 5 years or so, is rising quite a lot. It's rising even a bit in men too. So there is concern. Nobody's quite sure why this is occurring, but this is again a big issue right now, that we do not have really good treatments for some of the more common cancers. Resistance is also an issue. We saw that a lot of drugs affect the synthesis and the metabolism of DNA, but what we're finding is cancer cells can repair themselves faster than the drugs can inhibit the DNA. So resistance is a big issue too. So we're obviously working hard to develop other ways to treat cancer, and you got a sense of that with some of the newer agents, the targeted agents, the biological agents, but we still have a great need to have better, safer, better tolerated anti-cancer drugs. In terms of future perspectives, we're going to see more and better targeted therapies. We have plenty of cytotoxic chemicals, drugs that hurt the cancer cell but at the same time are toxic to the healthy cells. So hopefully you got a sense that these targeted therapies give us a much better way to do this, to try to focus directly on the cancer cell, and this will improve in the future. More vaccines. A vaccine, talked about briefly during the talking about antiviral drugs, a vaccine is sensitizing the immune system to deal with certain cancerous tissues, and we have several now, and we will see more in the future. Drugs that protect the healthy cell from the more traditional chemotherapeutic drugs can be also very helpful. Again, fairly new at this point and sort of in its infancy, but we may see more of these drugs too. And a big issue is the so-called personalized oncology, that we are going to tailor treatments more based on the individual characteristics of each tumor in each patient. As we learn more about the human genome and we can follow the genetic background of each type of cancer, we're going to get better and better at this, and less trial and error of trying to find the right cancer regimen for each patient. So the future looks bright. We should also never forget that prevention and early detection are also important, and we can help remind our patients of that as well. Using sunblock, not smoking cigarettes, regular screening in terms of breast exams, colorectal screening in terms of colonoscopy. These are also critical, and we should not lose sight of that fact, and again, hopefully remind our patients of that fact. So this concludes our discussion of cancer. Very important drugs, and you have to, as I said, hope that the future is very bright in terms of improving our treatments and getting treatments that are effective and much better tolerated.
Press pause and read this slide before proceeding to the next one for the answer.